it really is a pleasure to be here and to be able to introduce this event. We're working in very close partnership with Amref, and Professor Osur is a key linchpin in that whole process. So to give you a little bit of background on him, Professor Osur, he's the Vice Chancellor at Amref International University and the former Technical Director at Amref Health Africa. Amref is Africa's largest indigenous health non-governmental organization, and it's been working on community health across the continent for decades. The university is a more recent undertaking, but it's really taking hold with increasing courses available, a growing student body, and linked to Amref, the NGO, it's very well situated to provide an excellent education on health. So it's a really exciting thing to watch happening. Joachim himself, Professor Osur, is a health development professional and academician with very wide experience in health programming across Africa. He has supported a lot of African governments in developing health policies and service delivery models that bridge the gap in access between the poor and the rich. So his interest in inequalities is long-standing, and I'm excited to hear the insights he's going to share with us today. He's also a researcher with interests in health systems, sexual medicine, and reproductive health, and is very well published in a range of journals. He holds a bachelor's degree in medicine and surgery, a master's in public health, and a PhD in reproductive health. And he's also fellow of the European Committee on Sexual Medicine. And just to say, this feels like quite a personal event for me. I started my public health career working at Amref, and I've stayed very closely in touch with them over the years. And now what that means for me is I'm very lucky to be collaborating with Professor Osur. And over the last year or two, really in the context of this hub that we're working on in Kenya, we've worked together on how the COVID pandemic and government's responses to it have brought to light and really exacerbated inequalities. We've looked into how community health workers might help better meet communities' health needs during the pandemic and beyond. And we're investigating the potential for self-care interventions to also bring care closer to communities. And as the hub expands, we hope to really increase the number of opportunities for the broader USC community and the broader Amref and Amref University community, including the potential for things like educational exchange, joint courses, and of course, engagement in joint research. So as you can see, Professor Osur brings a breadth of knowledge, a depth of experience that's quite special. Also special is his commitment to improving health and reducing inequalities. And I have to say, he's a lovely person, he's an inspiring colleague, and I'm very grateful to him for joining us today and talking about health inequality in Africa and what needs to be done. If you have any questions throughout the talk, please put them in the Q&A function, and we'll make sure that we have some time for those questions after the initial presentation. But in the meantime, it gives me enormous pleasure to hand over to Professor Osur and invite him to give his talk.
Okay, thank you, Laura, and thank you everyone for attending. It's a great pleasure to be invited to this talk. And we are really happy as Amref International University to be collaborating with the University of Southern California. We've talked about a possibility of virtual exchange programs, especially for our students, as well as our staff. And so this may be the beginning of a very interesting collaboration where we'll be exchanging a lot of knowledge and experiences between us. I will project some slides, so allow me to do that. And I hope people can see my slides.
Yes, that's perfect.
Perfect, thank you. So the topic is historical perspectives on health inequality in Africa. And we are asking if there is light at the end of the tunnel. And in this talk, we are going to talk about three things. First, the complex foundations of health inequality. And secondly, addressing contextual factors that cause health inequality in Africa. And the third one is dealing with colonial legacies in enhancing access to health. Let me start by saying that health inequality is an indicator of general inequality in society. And it is important to start by defining inequality, the opposite of which is equality. Thomas Jefferson in 1776, during the occasion of US Declaration of Independence, said that we hold these truths to be self-evident, that all men are created equal and not created in red, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. Now, this was followed 172 years later when the UN had the Declaration of Human Rights in 1948, and they said all human beings, this time not created, are born free and equal in dignity and rights. They are endowed with reason and conscience and should act towards one another in a spirit of brotherhood. Now, the question we may want to ask, are people created or are they born? And why the difference in language when we are talking about the same thing? Which brings me to an interesting analogy by someone called Auguste Comte. Auguste Comte is a sociologist. It's actually called the father of sociology. And he theorized that societies develop in knowledge over time through three stages. That the most rudimentary stage of thinking is theological, which is fictitious. And in this stage, everything is attributed to God. And many times people have many gods. And anything that happens is the cause of the gods. And he said that this then develops to a second stage, which is metaphysical, where people start to realize that actually some of the happenings can be explained by natural occurrences, but that those occurrences are difficult to understand. And so in this stage also, the gods become monolithic. People start to think of a one God and start to try and explain some things by natural forces. The third stage, which is the positive stage, they call it positivism, is the scientific stage that most of us now ascribe to, where we use scientific methods to explain occurrences in nature. So when you start thinking of Jefferson and the UN, it might be that maybe Jefferson was thinking more theologically and the UN maybe more metaphysically. But I am more inclined to be scientific. I think I'm more positivist. And in that sense, in my many years of working as a doctor, I've seen that actually we are neither born equal nor created equal. When you look at a newborn, they will not have the same weight. When they start growing, they grow at different paces. And when you go to school, when I went to school for the first time, I realized people are gifted differently. Some are footballers, some are comedians in class, some are mathematicians, others are historians. So we are all different. And so I don't think we are born equal in all aspects. There are a lot of unequal aspects that we have. So there are inherent differences that we have. And we are then also born into contextual differences. We are born in different geographical areas which have different influences on our being and well-being and health, and different cultures and different political systems. And so we are born unequal, and we also live in an equal world. Now, therefore, to be able to talk about inequality, we have to understand, we have to come up with a matrix which we are able to use to explain the individual factors that cause differences, the contextual factors as well that cause differences, geography, culture, political systems, and also the historical factors. And in Africa, very important, the colonial legacies that make us different. So we are born unequal. We find ourselves unequal even more because of the differences that we face in the world. Now, and this brings me therefore to the concept of equity. Do we want to be equal or to be equitable? That is something that we need to talk about. And it is important to bring this issue because when we talk about affirmative action, for example, when we say some people are more equal than others, it should be understood. This picture shows 3 people watching a football match. I think many people know this picture. The short person and the tall person and someone in between. If you give them the same tool to watch football, that is equality. And they will not see football the same way. But if you give them different tools, they are able to see football the same way. And that is equity. Equity is giving people what they need according to their need. Aristotle, one of the philosophers, talking about this, said that we must distinguish between numerical equality and proportional equality. And he said that it is unfair, it would be unfair to treat each person the same way, given that they have different needs. And so equity is important in focusing on health inequality, which brings me again another concept of justice. Justice is fair treatment of all persons. So when we talk about justice and social justice for that matter, we are inclined not to advocate for equal access, but for equitable access, economic opportunities to education, to health, because we are all different. We are created or born different. Now, so the big question is, do we need health equality or do we need health equity? And I must say we need both the equality and the equity. And the puzzle actually is to define whether what we need to be equal, what we need to be equitable, and what we don't need to be equal or equitable. If we can solve that puzzle, then we can achieve health equality. So the task, this is what I'm saying, in resolving health inequality is to solve that puzzle. What do we want to be equal? What do we want to be equitable? And what do we not want at all and should neither be equal nor equitable? Let me start with what should be equal. Then I will talk about what should be equitable. And finally, what we do not want to be either equal or equitable. And what we want to be equal, to be able to achieve equity in health, is power. Power is defined as ability to influence. And when power is not equal, then it can result in others having advantage over others. Power is known to correlate with health. The more power one has, better health they have. This has been shown scientifically. Differences in power result in inequalities in health outcomes. In the Africa setting, power differences have resulted in two health systems, basically. And so when you think of a rich African man or woman, when they get a small cold, they go to a high-end private hospital. And when the sickness becomes serious, they're always flown out of the country. I don't know whether you've ever wondered why rich Africans don't die in Africa. It's because they are in a different health system, which kind of merges with the health system in a developed country, and the referral system, and everything is well set for them. This is different from a poor person. A poor person, when they get sick, they go to a dilapidated health facility somewhere in their rural area, sometimes with no drug, sometimes without a qualified health worker. Sometimes they have to wait for hours on end, and people are known to die while queuing. When I was a student in Kenyatta National Hospital here in Kenya, it was normal when mothers come with their babies to have a few deaths on the queue. And we always knew when you hear a mother, when you heard a mother screaming while queuing, you should run there with equipment to resuscitate, and some of them would die on the queue. That is the reality of power imbalance in access to health. It creates two health systems. In Africa, those two health systems are very obvious. Now, balance power, there is only one way of balancing power. There will always be powerful people, but to balance that power, communities must come together. People must come together and speak with one voice, balance the power between the poor and the rich. But what we see in Africa commonly is a fight back by those who are in power. The civic space keeps shrinking. Social accountability is a problem, and a lot of people suffer adverse consequences for mobilizing, for putting people together, talk in one voice. This picture here just shows something which happened very recently, where in Uganda, where the president has written to all donor agencies demanding power to determine which NGOs get funding. And it is because the power in Uganda, the government in Uganda has realized that there are people who are mobilizing, and when they mobilize and speak in one voice, it is difficult to control them. So these days, what governments do, they shut the internet, they shut Facebook and other social media outlets, and they control who funds these civil society groups, and they jail the leaders of those groups so that equality in power is not achieved. People get frustrated. People get frustrated, and as a result, we've seen upheavals. You may know that in the last less than 3 months, I think, we've had coups in Africa, in Mali, in Guinea, in other places. People get frustrated and they take action and they overturn their government, sometimes forcefully, deaths happen and so on. And so what I'm saying is, for us to achieve equality in health, we have equal power, and that power can only happen if civic space is available for people to come together and speak in one voice, balance the unequal power that is in countries. Let's go to the second thing, which is what should be equitable. Power should be equal, but what should be equitable? There are a number of things. The first one is social determinants of health, which we need to address equally for all people. We cannot change, as we've said, the inherent differences we are born with, but we can change the cultural factors, the environmental factors, the political factors that affect our health. You may be aware that a child born in Africa, for example, is likely 16% likely to die before the age of 5, compared to a child born in a developed country. You may also be aware that many children in Africa, a part of them, are born in poverty. And when they are born in poverty, they are stunted, and their physical and even mental development may be compromised, and forever they may never have good health. When you think of unemployment, for example, it is estimated that 60% of unemployed people in sub-Saharan Africa are the youth. Now, we know that lack of employment, lack of income, all these things lead to adverse health outcomes. Poor housing, we know, is a major cause of respiratory diseases in households in Africa. So there are many, many factors that happen where we live and determine health. Africa has generally not done well in improving social determinants of health across the board. And I dare say, maybe we need a serious policy change. And for me, that policy change would be to abolish the Ministry of Health and instead have health in every ministry. Because social determinants of health are not about the Ministry of Health. They're about housing. And when you come to African cities, you will see the photo I've shown here. There are parts of cities that are slums and then parts which are not slums. And the disparities in housing are a factor in the health of the people. When you think of climate, when you think of agriculture and the chemicals people use in their farms and the rainfall problems and the lack of food, food insecurity, all these things lead to bad health. And so the only way we can start to attend equally social determinants of health is not to have a Ministry of Health, but to have health in all ministries, so that health is a mainstream factor in transport, in agriculture, in housing, and in every other ministry, rather than being a concern of the Ministry of Health. Now, the second thing which should be equitable is financial risk protection. And this slide just shows the different ways in which health is funded. In sub-Saharan Africa, you may be aware that we have 15% of the world population in Africa. But these 15% of the world population have 25% of global disease burden, and only 1% of world's health expenditure. So only 1% of money spent on health is spent on this group. Out of pocket health expenditure ranges from 75% in Guinea to about 7% in South Africa, with an average of 34% across the continent. With a big proportion of the population not insured, the risk of sliding into catastrophic health expenditures is high, with the risk of a vicious cycle of poverty and disease existing all the time. And so giving financial risk protection, which is basically a big issue in universal health coverage, is very important, and making it equitable across the board is what is needed to achieve equal access to health. The third thing which we should make equitable is quality of care. And I've already talked about two distinct health systems existing in Africa, one for the poor and one for the rich and powerful. And if we can make standards of care equal to everyone, so that if I have pneumonia, the medicine I get is the same medicine someone else will get, whether they are from a rural community, whether they are rich or poor, that standards of care will not change simply because of my social circumstances. That is very important if we are going to achieve equity in health. Right now, as it is, we have distinct systems, and so it is not equal. Let's then talk about what should never be permitted. Social privilege. Social privilege. Now, let me start by defining it. Social privilege is when you access, in this case, when we are talking about health, it's when you access health where other people can't, simply because you bear some characteristics that those other people don't have. For example, it could be skin color. People talk about white privilege and issues of racism and anti-Black movements and so on are associated with bad health. So white privilege, good health. There is male privilege, and in Africa, male privilege is really a big thing. Because I'm a man, I have some privileges which the women don't have. And that again is not right. Sometimes in Africa, it is also the issue of tribe, which language I speak, can make me be privileged in some sectors. Sexual orientation can be an issue. Sometimes disability can be an issue in accessing health services. So many people, when it comes to social privilege, they are not even aware that they are privileged. They are blind to it. They may blame the less privileged person for their tribulations. And the consequences of being unprivileged, when you are not privileged, include limited chances, including access to healthcare, being stigmatized, being discriminated. White privilege, for example, is rife in a place like the US, where Black and white coexist, but it extends beyond that. I think even in Africa, we feel it in some way. If you think of COVID, for example, I think just the fact that there are Black people in the world, there seems to be unequal access to some of the COVID services, including the vaccine. So white privilege is there. And in Africa, as I've said, there are all these other issues. Now, what is the solution to the problem of privilege? It is to sensitize people to be conscious of their privileges. As education levels increase across Africa, many segments of society are becoming uncomfortable with some of these privileges. And so we are seeing a lot more talk around gender equality. We are seeing a lot more talk about rights for people living with disability. We are seeing a lot of talk about people with diverse sexual orientation. And one very important discussion which is really going on is the voice of young people because they have been disadvantaged in many ways. And so I think there is increasing voicing, which is good, so that people who are privileged are really aware of their privilege and are able to recognize that that is not just. We also definitely need policies to be able to do away with some of the privileges, policies which will ensure affirmative action. Now, so those are the three things that should be equitable or not equitable at all. And the last part of my talk, I want to talk about the historical issues that impact access to health. Now, I call it, we need to say no to social Darwinism. Let me start by saying this, that colonial legacies or the history in Africa, having gone through colonialism, is where local communities used to be considered barbarians by the colonialists. They were seen as full of disease and with no knowledge of how to protect themselves. As such, the colonialist designated himself or herself as a wise person who had come to save this barbaric generation. They used the theory of Darwin. Darwin, as you know, is a natural theorist. He talked about the theory of natural selection that based on the fact that resources are limited, organisms will adapt genetically and in other physiological ways to effectively compete for those resources, and so those which are fittest will survive, while those which are not fit will be eliminated from the world. So it is survival of the fittest, and we know that theory was good. It was true, and natural selection has led to evolution as we know it. But the colonialists used the concept of social Darwinism, and they said that it justified their action, that the black skin, for example, was underdeveloped, was a sign of underdevelopment, and people who are dark in skin needed help because they were not as developed. They used the theory to justify their social dominance over colonialized societies. They believed that the dark skin was underdeveloped. They put themselves to natural competition. That is what they said. And because they had the gun, they could shoot and kill. And so the poor colonized people could not compete effectively. And so they became the survivors in this unfit world. Now, the colonial mentality was carried post-independence in Africa by what we call neocolonialists, some black-skinned, who have worked in cahoots by remnants of colonial powers to continue imposing irrelevant programs on the people. A number of bilateral agencies and sometimes NGOs actually promote this, and they plan their programs elsewhere without involving communities, and they come and impose those programs on communities. I know time is running out, but let me give you an example of this. There used to be a lot of cholera epidemics in Kenya a while back. And so people developed programs and said each family must have a toilet and it must be clean and they must use it. And so the chiefs would go around inspecting homes, and homes which did not have a toilet, people were arrested and charged. Toilets were built in every home, but cholera did not stop. And those toilets were called the chief's toilets because the chief used to come and arrest you if you didn't have a toilet. So they built the toilets for the chief, but the cholera did not stop. And the reason is because they did not own it. It was not in their decision. Maybe they had a different solution to this problem. We've seen this with Ebola in West Africa. When communities were not involved, they even refused to take precautions and the disease could not stop. And so the colonial mentality of imposing programs without involving communities leads to mistrust of the health system and is one cause of diseases in communities and inability to control diseases. It creates lack of ownership of programs and it leads to programs not being sustainable. And so one thing we must deal with if we are going to have ownership of health and equality in access to health. Let me conclude by saying this. Health inequality is a complex subject and is a result of natural, contextual, and historical factors. Africa is far from achieving equality in health because power is not equally distributed among community members, and because social determinants of health disadvantage big sections of communities, and because sustainable health financing is a challenge and quality of health is not standardized. And also historical factors, especially colonial legacies, continue to negatively impact health in Africa. Thank you very much.
Thank you very much, Professor Osur. That was a wonderful overview of a very complex set of issues, and really grateful to you for pulling them together in that way, and really highlighting, giving us a lot of food for thought about what some of the challenges are, but also beginning to think about what some of the solutions might be. Professor, might I ask that you turn on your camera for the Q&A so that we can see you again, and I can, I'll start us off with some questions. If anybody still has questions, please do put them in the Q&A function, and we're just working through some of those as they come in. And one question that I think is critically important here is you spoke, well, a lot of people are speaking right now about shrinking civil society space, but I really appreciated your framing of this because you made it active. It's government action that is shrinking civil society space. It's not just something that's happening. There's a purpose behind it. And your example from Uganda, of like not wanting such a strong civil society voice to really challenge the people who are in power politically, and that's used as a way of maintaining this inequality in power, right? But it's political leadership that's needed to address inequalities, that's needed to address the social determinants of health that you spoke about as so important to this. So how do we reconcile that? How do we understand that we have governments actively trying to limit civil society participation, and at the same time, we need them to be taking leadership on social determinants and really actively addressing inequalities? And it'd be great to have your thoughts on that, if you could.
Yeah, thank you. I think it's about balance between systems and people. Where people are stronger than systems, then you have a problem. And the problem we have in Africa is that our systems are very weak, political systems, so that people tend to override systems. Because if systems were strong, elections would be credible. If systems were strong, it would be the voice of the people that would be represented in policies that we have. Someone would be listening and saying, this is what the people want, rather than this is what I want. And so it's about balancing, reducing the power of the person and strengthening the power of systems.
Great, thank you. That's again a challenging task ahead, but I think you're absolutely right. I've got a question here that's come in that says, Professor Osur, thank you so much for your time. I'm a medical student in Detroit, Michigan, and my parents are from Ethiopia. I'm actively interested in helping address the social determinants of health, both in the US and our home country. So what's your perspective on how to navigate competing interests when trying to address policy change?
Okay, competing interests against policy change. I think policy should drive, policy and law should drive whatever else we do. And I think where policy and law is disregarded and people don't do things according to policy and according to law, according to guidelines, whether it is health guidelines or health standards, then we have a problem. And so I would prioritize very much having policies, but also implementing policies and sticking to that. Yeah, and if we do that, then the other things should be able to flow more easily.
Mm-hmm. Mm-hmm. Thank you. The few questions that are coming in that really speak to the, I think, critical point that you made around community participation and the need for a feeling of choice, ownership, and feeling that one is taking control of one's life in a way, including in one's health. And so the there are, I guess, two practical questions. One is, especially thinking about the context of universal health coverage, how to incorporate the community in those kinds of programs. And I wonder if perhaps you could give a concrete example of a successful community-based program to address issues around health or the social determinants of health, to give a sense of how best you think this can work in reality.
Let me give now that there was a colleague from Ethiopia, the one from Detroit, talking about Ethiopia, let me give the example of Ethiopia. Ethiopia has had a very good community health system model, which goes right down to the villages with village health committees, women's health army and all that, and having health posts in every village. Where that has been implemented, health indicators have improved dramatically. And I think that's a good example of what works. And if we can strengthen our communities, most countries actually do have a community health strategy, but it is not funded and it is not implemented. That is where health starts. If we can have a strong community health program, which is owned, which is funded, which has good leadership, then it is the beginning of realizing health for the majority in the countries. Yeah.
So for you, it's really about starting at the community level and really trying to bring health as close to the community as we can. And as you say, there are good strategies for that. And I think about sort of the community health worker networks that you work with in Amref that stretch across many countries. Like you say, there is an issue about funding. And again, I wonder what role do you see for civil society in advocating for more funding going to community health than, for example, fancy tertiary hospitals in urban areas that provide very high-tech solutions that few people will ever access?
Yeah, so there are two things. One is funding, and the second is getting value from the fund. Mm-hmm. A lot of funds that are allocated to health right now don't really reach the person they're supposed to reach. And a lot of it, of course, from government, but even donor money does not always reach the recipient. There is a lot of pilferage in between the donor and the recipient. And government money, there are a lot of wastages along the way as well. So it is allocating money and also using it correctly. And this is where social accountability becomes important. Someone needs to check that the promise has been made and also achieved. There are a lot of promises governments are making. There are a lot of promises donors are making. They are saying we will give you good health, we will give you UHC, we will give you national health insurance. But at the local level, they don't feel it. And so if we can organize ourselves at the local level and say what is really happening on the ground versus what has been promised and even funded, that will be a very good starting point. But definitely there is a lot more need to have our priorities right, put more money in health. If we have healthy populations, they are more productive and countries develop better. If we have a sick population, we spend a lot of money in treating them and development cannot happen. So let's put our priorities right. Health is important, it's a development issue. Let's fund it and let's fund it well.
Great, thank you. And I think you raised another really important point there, which is really about movement building and about the people's voice and having a population who understands the importance of these issues and really trying to use civil society as grassroots movements in social accountability that I think can be very, very powerful. I wanted just to switch a little bit. There's a lot of interest, understandably, in the issues around the colonial legacy and how to think about that. and recognizing that the impact of colonialism is also felt in terms of the structures, in terms of the way that health systems were designed under colonial powers, was really to serve the colonial elite. So you have health systems that are very much focused in urban areas and not designed to reach the hardest to reach, who now might be those living in a greater situation of inequality. So I think that the question is, how do we take this on? How do we really try and address the colonial legacy? And to what extent can this be done domestically? To what extent is there an international responsibility to contribute to this without dictating how it be done? There's the whole balance of power thing that comes in, but when you think about the history that has exacerbated inequalities, how would you see, what are some next steps that might help redress some of that?
Yeah, I think the important thing for me in addressing this neo-colonial issue and colonial legacies in health is for us to co-create health programs with communities. Let me take the example of COVID, and I know the whole world has faced it. When we decide, for example, that we are going to have lockdowns, because we've seen them work in China, and then we come to Africa and say, we have now locked down everyone. The Maasai community, which is very known in Eastern Africa region, and the Fulanis in West Africa, who are nomadic, how do you lock them down with their cows? You know, what about the market woman who sells their vegetable? We don't have supermarkets in many parts of Africa. We don't have home deliveries. People meet in markets, sell their wares and their products. So what happens when you lock them down? The food rots in the garden, and someone goes hungry elsewhere. So it is because we did not co-create a solution to control COVID. We didn't talk to each other and say, in our community, if social distancing is the problem, we have a way of doing it. And when you look at most of the communities, they will tell you when there was a disease which killed people, how they did it. So they have some community knowledge which can be used. And we need to contextualize health interventions, which by taking care of that community knowledge and merging it with what we know scientifically and co-creating and owning those programs. I think it is time now that we should be clear that nothing for us without us. If we are in a community, unless we've discussed your program, let's not have it, because we want to have our voices in there. We want to contribute our local knowledge in there. We want to own it. We want it to be useful to us. So you may bring money in, that is good, but that money can go to waste unless we enhance this local involvement. And that for me is the solution to colonial legacies. And health policies that we make in countries to take cognizance of that. It should not be cut and paste from other countries, and it should not be cut and paste from the colonial time. That is why maybe I'm saying, let's abolish Ministry of Health and just have health in every ministry.
So absolutely, and again, there's a question about that too. You know, I think that so the comment that's come in says it's an excellent and challenging talk. Your suggestion of health in all ministries makes great sense. That said, in gender, one of the things that we've seen through mainstreaming has been that the focus ultimately gets lost if there's no champion. So how can we mitigate this to achieve equal access to health?
Champions. Yes, I think champions will arise where there is need. And I think this is why we are having challenges of civic space being limited because champions do rise. And there are many champions who are rising to advocate for health for all, equal justice for all in health. What we need to do is to create a civic space that allows champions to arise, that allows voices of reason to be heard. And that is really the big challenge we have.
Mm-hmm. Thank you. And I guess there's a couple of questions that have come in about civil society and the role of civil society, but also so that civil society playing a watchdog role on the government, the idea of social accountability that you mentioned as something that's really critical, but linked to that, how to address issues of corruption in civil society or accountability for civil society action, and whose role is that, and how does that play out in terms of ensuring that we really are reaching the people who are left behind and we are making the most difference, trying to reduce inequalities?
Yeah, so that is a point that has been really used by people who would not like to see the civic space grow. They look for the bad apples in the civil society and use them as an example of how bad civil society is. That does not mean that civil society is perfect. We do have cases of corruption and all that. I think the solution lies in self-regulation. And of course, you still need a law for that to happen, but civil society needs to self-regulate. And if they self-regulate, they will identify those spoilers and kick them out of that space.
Right, so there's a mutual accountability within civil society with organizations kind of watching what everybody else is doing. That
True.
Right, okay, thank you. I think I wanted to kind of zoom out again for a minute. You know, the SDGs is our guiding framework for sustainable development goals around health and development at the moment. And to some extent, they aim to address the social determinants of health on the assumption that this will in turn reduce inequalities because the focus is no one left behind, right? How best do you think we can really monitor progress in ways that truly address the inequalities that you're speaking about? How do we track this?
So that's really another big challenge. One of the weaknesses we have is even to capture the inequalities, data issues, and monitoring system issues. It is part of the weakness that we see in the health system. Now, definitely there is need for a bit of capacity building for government, for civil society, for digitalization of data systems, and of course funding of those data systems to be able to capture what we need for policy. But this is an area again where civil society can be very important, in addition to regular data that we collect, vital statistics and so on. I think quick surveys by civil society can help. I also really think that qualitative data, people's stories are very important, and ability to present that data in a consumable way. I think, again, when you think of colonial legacies, the issue of research and how data is used from research and all that is out there as well. But we could do quick surveys, we could do human stories, and we could also strengthen the usual data systems to get enough evidence for policy advocacy.
Fantastic. I really, I love the idea of not only strengthening the data systems and the quantitative data being collected, but using human stories alongside that to humanize these issues and to remind all of us that we're not talking about inequalities in numbers in an abstract way, but this is really about people and people's lives. And there's a common humanity that we need to come back to. I know that we're almost out of time. I'm going to try and squeeze in one more question, and I'm having a hard time choosing. But there's one here that says, thank you, Professor Osur, for your thoughtful presentation. Please comment on your thoughts about the role of current donors leveraging their donations to require governments to increase the percentage of their national budgets to healthcare. Can you point to an African nation that has increased their own contribution to their health budget and achieved notable successes in health outcomes?
Yeah, I think that is a good donor strategy for increasing finances for health. Whether it worked is another story. I don't know because I'm yet to see it work. We actually, as we talk now, have a problem because most governments are not meeting their own promises when it comes to funding of health. People talk about 15% of national budgets going to health, Abuja Declaration and all that. It's not happening. And so if there is a way that donors can match their funding with increase in health budgets, maybe that would help. Africa is very rich. I think we need to change our mentality. We have a lot of money. It's about governance, it's about priorities, and it's about being strategic and consistent in the way we manage our resources. A lot of countries which were similar to Africa before, African countries before, have passed us, and we've remained behind because of governance issues and how we prioritize our needs. And so we can fund our own healthcare. And I think social accountability is one thing that we need to strengthen for us to do that. Thank you.
Fantastic. Professor, thank you so much for ending on a positive note, I think, of how we can move forward and do this, and recognizing that it is possible to shift these power dynamics. And with some strengthening of governance, there's a prominent role for civil society in there, obviously. I think there is some optimism that we can help to reduce these inequalities in health across the continent. So I would love to keep asking you questions. We have many more, but we're out of time. So I really want to thank you very much for taking the time and for coming to share these thoughts with us today. I hope that they will provide a foundation for our ongoing collaborations, and we can build on some of these ideas with other faculty and other students in our respective institutions. And we're really grateful for all of that. I also wanted to thank all of you for participating, for being here at the talk. It's wonderful to see so many people here. As Sophia mentioned, we have other talks coming up later in the semester. The next one is in 2 weeks' time on the 19th, which will be around climate. So when climate is everything, how do we manage the world and leave no one behind? So as you see, our theme of inequalities persists, but we'll be changing focus to the area of climate in 2 weeks. And I really hope to see you all there. So thank you very much to everyone.